time. I think so. Here we have some diagnostic challenges in neurophthalmology. Of course, in our practice, we see many situations where the diagnosis is not very straightforward and where it is important to look at the subtle aspects of some of the conditions and some of the newer modalities of some of the diagnostic techniques. So we have with us Dr. Rohit Saxena from All India Institute talking to us on how to go about a case of optic neuritis. Dr. Rohit Saxena.
Thank you, ma'am, for the opportunity to be here and keep me a part of your course. I'll be giving you a brief overview of management of optic neuritis, and actually it is so complicated and truly we are still learning about it. It happens every few decades or centuries. Man thinks that he knows everything he needs to know about it, and suddenly a revolution comes and everything gets changed. So after the ONTT, we thought we very easily we understand what optic neuritis is, and we have the treatment sorted, and we just have a few patients we don't understand who don't do so well, and suddenly all hell broke loose with NMO and MOG, and every few years we have new antibodies, new types of neuritis being discovered and discussed, and management options are just exploding across the board. So I'll try and give a very simplified clinical approach and understanding of this. It is now becoming so difficult and complicated that probably none of us here can truly say we understand the disease at the moment. So just an overview for general ophthalmologists and for anybody who may come across a patient like this. So optic neuritis essentially defines as inflammation of the optic nerve because of any reason, and the clinical presentation will depend upon where or which part of the optic nerve is getting involved. So the optic nerve head, you will have papillitis kind of a picture with edema, which is maybe a few posterior vitreous cells, hemorrhages, or else it could be a retrobulbar neuritis with a normal looking fundus. The typical, so ONTT defined to us, told us exactly what typical is, and that's how we understand typical now. Typical essentially would present with uniocular optic neuritis, predominantly more likely to be in females or more commonly seen in females between 20 to 50 years of age group. There would be some pain associated with the visual loss, which would be fairly sudden, and the visual loss will worsen over a few days up to about 2 weeks, after which it will stabilize, and by 3 weeks or so the vision should definitely start recovering. In unilateral cases, there has to be an RAPD localizing it to the optic nerve. So optic neuritis or any optic nerve, any optic function deficit is going to present to us within relative afferent pupillary defect, and as I mentioned, the fundus may be normal or may be showing papillitis. Now this was what a typical optic neuritis was defined as, the kind of classification with ONTT used to include patients and define them as optic neuritis. Now we understand that that is just one category of presentation, and things that present other way around, and a large number of patients will present the other way around, which may be very sudden loss. There may be very severe pain or very minimal pain or no pain, bilateral involvement outside the ages that we talked about, very severe edema, hemorrhages, progression of vision loss beyond 2 weeks, or there is no improvement spontaneously or even after treatment. There are multiple recurrent episodes of the same event happening in the same or the other eye, and no RAPD in unilateral. Actually, really you would rule out optic neuritis or optic nerve involvement itself, because it's very unlikely. You are not going to have something like this. So again, why are we using these terms? Because like I said, they are now in an entire spectrum, so there is no categorization, but we still use this categorization mentally when we come across a patient, because patients with typical optic neuritis are more likely to be either isolated demyelinating or may not be associated with multiple sclerosis. So typical optic neuritis more likely to be demyelinating or isolated optic neuritis without MS. Atypical optic neuritis, on the other hand, so if you have any of these other presentations, it's more likely for it to be associated with any of the autoimmune disorders, NMO, MOG, a lot of other inflammatory lesions, including an infectious etiology. So these are things. So when you have these kind of presentations, start thinking like this, so that you understand your differentials and you start your approach. The diagnosis remains clinical. That's why it's important to have these clinical understanding of these clinical presentations, highlighting again the importance of RAPD. In unilateral cases, the vision loss may be variable. Patient may just come with a subtle field effect, or in early cases may just talk about a bit of color desaturation. So color gets particularly early involved in any optic nerve. So patient may just come with a little desaturated color appearance from one eye versus the other. Otherwise, any visual function may be affected, color, contrast, fields. You will have an increased latency on the VEP, and of course, the OCT may mirror what you are seeing clinically on the optic nerve appearance, and may not have too much of a diagnostic. Now, the second step, what we want to do, the next most important step, is the role of MRI. MRI is now no more an optional modality. CT scan tells you nothing unless you have a suspicion that there is a space occupying lesion and I want to urgently get over with that, because if that is, I'll refer the patient to a neurosurgeon, otherwise I will manage him. So there is no role of any other modality other than an MRI, and the MRI that you need to advise is MRI brain in orbits with contrast. The other few things you may add is fat suppression. In the orbital part, you suppress the fat, you're able to delineate the optic nerve well, and a flare. So a flare will suppress the fluid responses, and you'll be able to identify well the periventricular plaques that exist. So when the CSF fluid is white, the ventricles are white, subtle periventricular plaques get dampened. When it's black, when you have suppressed the fluid response, you will get those highlighted, and that will help us to identify them. So that's the most important thing. If you don't understand, if you don't remember all these, just write an MS protocol. It's now a very standard terminology. Rarely, occasionally on the first go, I would advise an MRI spine, although neurologists are a lot more insistent. But if you have a history of neurological problems, patient has ever talked about bowel bladder problems, has talked about weakness of the lower limbs, any evidence of any other neurological involvement, you should probably get an MRI of the spine also. So ONTD taught us that IV methylprednisolone for 3 days is the standard of care, followed that up with a small oral taper. Now, we of course had used dexamethasone. Nowadays, we actually don't talk about it because we have so many other things, and dex has not been actually evaluated in them. But so suffice to remember, IV methylprednisolone, we have now modified from 3 to 5 days depending upon the severity and the response. So IV methylprednisolone 1 gram a day for 3 to 5 days, followed by an oral taper. And in the meantime, depending upon the clinical features and the investigations you have ordered, your next step will be, if you are thinking of optic neuritis, if there is multiple sclerosis, suspicion of multiple sclerosis, you got your clinical presentation of a typical optic neuritis, you've seen that patient, you get an MRI brain and orbits done. In the brain, you may see subtle signs of multiple sclerosis. You are thinking of MS, or if there has been a recurrent optic neuritis with good recovery, again you are suspicious of MS, you may start discussing with the neurologist about disease modifying agents and long-term therapy to prevent recurrences. It has been shown that these disease modifying agents and a lot more that are now available have reduced the rate of relapses in these patients. Now, so that is all about typical that we wanted to know. Now we have a patient who has presented to us atypically. There is some atypical sign, non-recovery, very severe visual loss, bilateral involvement. So we start thinking about NMO or MOG. So NMO is a antibody generated against the it's a neuromyelitis optica spectrum, and it is acting through the antibody mediated pathway. It may present with bilateral involvement, recurrence, severe visual loss, poor recovery, all the things we listed as atypical. So what we used to call as atypical are actually NMO and MOG. So important to separate, because treatment of NMO, first step IV methylprednisolone, but do not give disease modifying agents. They have shown to worsen outcomes. So we talk about immunosuppression and alternatives to prednisolone. We may have to give methylprednisolone or even oral prednisolone for a much longer, 3 months or longer period. The other antibody associated is MOG, associated with very, very recurrent optic neuritis, not such a bad outcome in the short term. In the long term, again, recurrent damages may cause visual function deficit. Again, may present with bilateral involvement. In children, it can present as an ADAMS, and these are important. The moment you have a child with ADAMS, think of MOG. It's now becoming equally important. MRI, the features are different. I'll just show you the photograph. The first one on the left is the NMO. So you have long tract involvement going right up to the chiasma. In MOG, you have long segment involvement but remains anteriorly. Multiple sclerosis is going to have short segment involvement, and just that part of the optic nerve is going to be affected. The brain features are also very different. The one extreme right is the MS. You can see the periventricular plaques, also termed as Dawson fingers. You can see in NMO you have a large area, especially in the inferior tentorial area, that you're going to find these lesions. And MOG may have again a spectrum which is wide. You may have spine involvement severely in NMO. So these are important things, differentiations that in the very beginning, that's why now MRI has become clinically all that important. So you have an optic neuritis with clinical typical features. You may MRI, IV steroids, improvement, follow up. No significant improvement or long-term steroid therapy is required. Revisit history. Start thinking of it as an atypical involvement. In the MRI, if you get suggestions of anything other than a typical optic neuritis or MS related, you will have to do other things, and you tailor your management accordingly. So there are a lot of long-term option treatments available. Obviously, you need to do that in association with your neurologist. So to conclude, optic neuritis is very, very frequently part of systemic disorders. You need to know which systemic disorder it is part of and work accordingly. Your management is to be very specifically tailored to the treatment that you are giving, and of course you have to work with your neurologist to manage all these things. Thank you very much.
That was a wonderful talk, Dr. Rohit, with a lot of customization need to be done for each of the condition of optic neuritis now, and investigative also.
Yes.
Thank you.
Thank you, ma'am. I'm sorry, I'll take your leave for
Yes,
the session.
I
Thank
know you are having the myopia session. Yes. Thank you. So next we move on to the next talk is Dr. Sumita Agarkar. She will come after her session in the other hall. So now another dilemma is double vision. When a patient comes with double vision, I hand over to Dr. Meena CK. She is a pediatric ophthalmologist in Little Flower Eye Hospital, okay, Cochin.
A very good morning to all. At the outset, I would like to thank Leila Madam and AIOC2024 for this opportunity. I'll be speaking on investigating a patient with double vision. As all of us, okay, double vision or diplopia, it's usually due to misalignment of the eyes with an absence of the fusion of images at the cortical level and each eye perceiving images separately. So always it need not be due to misalignment. So it can be due to neurogenic causes, and it can start from the nerves, the neuromuscular junction, or the muscle itself can cause, and also local ophthalmic causes. So how to approach a patient with double vision? So whenever a patient comes to you with double vision, you have to get a detailed history, and then itself you can come to a more or less a come to a diagnosis. Not the correct diagnosis, but at least it will lead you to a diagnosis. So first you have to see if it is monocular or binocular, if it is of acute onset, which can be dangerous, and if it's long standing, that is if it is intermittent. Then you have to find out what type of double vision it is. It's whether it is horizontal, vertical, oblique, and mode of onset, like if there was any trauma, any iatrogenic causes, like if they had any surgeries, example is sinus surgery, and diurnal variation, which involves more of muscle involvement or neuromuscular junction involvement and associated features. Now coming to the monocular part, always you have to occlude either eye and see whether it's monocular. Most of the monocular double visions are due to local causes. So you need a proper examination of the eye to make sure that it's not monocular. So monocular common causes could be even with severe dry eyes. You can get keratoconus, subluxation, and also take a pinhole vision and a proper slit lamp examination. So first rule out whether it's monocular or binocular. Now coming to the binocular one, which is we are more concerned about, and also which needs a proper diagnosis, you can think of a committant part and an incomittent part. That is, incomittent, when in an ophthalmologist point of view, you track towards a third, fourth or sixth cranial nerve. It's not that you have to not think about the other cranial nerves, but your main concern will be the third, fourth or sixth cranial nerves, or a combination of them. And coming to the committant part, or the non-paralytic, that what I mean is that you have normal extraocular movements. Then you should think of conditions like uncorrected refractive error, especially in the presbyopic age. People who resist using glasses, they can come to you with complaints of double vision. So always rule out that. And also the acute acquired committant esotropias, which has become so rampant in the COVID times because of increased screen time, so you have to rule out that, and decompensated strabismus also, especially intermittent exotropias, where they can come with double vision even at an older age. Now, in any forms, you have to go for a routine ophthalmic examination, which will include with a head posture, which start with a head posture and ocular posture, and you should think of turns which usually occurs in horizontal problems, and tilts and chin elevations and depressions, which usually are due to the vertical muscle problems, and also the associated features of the eye, like as you have in ptosis. So this child you can have the typical head posture of head tilt and a chin depression. She had a trauma with an injury to the inferior recti muscle, and she could read only in this particular position because of the double vision. Now the routine examination of the eye, where you have to give a little emphasis for the orthoptic evaluation, and also the pupil needs special attention in cases of double vision. Now coming to the extraocular movements, the assessment of extraocular movements in single nerve palsies, it is usually you can come to a diagnosis with the assessment of the extraocular movements. So the versions are important, and you can assess the versions first, because in conditions like gaze palsies, where ductions and versions can be different, so versions help in assessing the gaze palsies, and also you can compare both the eyes in versions. And ductions are usually uniocular movements, and vergences, where the eyes are moving in different directions. So versions, the help of the version, the main importance of versions is that you can compare both eyes. Like if you have a subtle overaction, you may not make out if you do it in a duction, and also you have to assess it in all the 9 cardinal positions. Especially here you can see that's a very small inferior oblique overaction, which you may miss if you don't examine both eyes together. Now ductions, obviously they are uniocular movements, and significant changes like this, or very obvious changes, where you can see that there is a very significant limitation of the abduction, which is obviously due to an abducent palsy. So such things you can get an immediate diagnosis with just assessing the duction. And third nerves usually adduction, elevation and depression, and fourth nerves torsions. And vergences, the convergence insufficiency and convergence problems is yet another cause, which I missed in the earlier committant part, are problems that can cause double vision. So you have to assess your convergence extent and limits, and divergence limits. And whenever you do an extraocular movements, you try to document them. So that is very important, because when you go back into the chart, you know that how much of limitation the patient had, and when they come for follow-up, you can compare it. Like here you can see that the eye is not even coming to the center. So you can say that when it's in the center, you call it as -4 limitation, and if it's beyond that, you can grade your limitation. So this patient, the eye is not even coming to the center. It's almost like a -5 limitation of abduction in the right eye, which was a 6th nerve palsy. And here you can see a significant overaction of the inferior oblique, that is in and up. So here you can document. So documentation of extraocular movements is important. Now, this is one form of palsy that is difficult to assess, like superior oblique palsy. The patient might come to you with the typical symptoms like walking down steps is difficult, and suddenly they have developed a double vision, and the deviation is usually subtle in such cases, in most of the cases. So the head tilt test is a very important test in especially in hyperdeviations. Like here you can see that on head tilt to the left side, there is a significant hyperdeviation. So this head tilt test has to be done whenever you see that it's ideal. It is better to do in all cases of especially in very small forms of hypertropia. So head tilt test, it must, and also you have to measure it when you get an idea as to which muscle is overacting or underacting. Now, before you go on to covering any eye or either eye, you should do a proper sensory evaluation. This is mainly for malingers. So many children come to you with complaints, parents complaining that the child is seeing double, triple and all. So better to do a sensory evaluation before you do a cover test or anything, because if they have a very good stereopsis, it's unlikely that they are having diplopia. So otherwise also any orthoptic evaluation, it's better to do a sensory evaluation first before you go on to a motor evaluation. And you have to assess all the 3 grades of binocularity before you go on to measuring the deviation, if any. So now when you feel that the deviation, you have a doubt, like diplopia charting is a very good tool. Diplopia charting you need not do in all cases. Like if you're sure of your diagnosis, then it's fine, but still for documentation it is extremely useful. This is not the ideal condition how you do, like ideally you have to do it in a dim lit, dim illumination. I'm just showing it to show the demonstration by the patient. So the patient should demonstrate how they see the images. So it is shown that torch with a slit and a red-green goggles for the patient. It is shown in all the 9 cardinal position, and the patient has to patient himself demonstrate how he sees the images. So what are the conclusions that you get from a diplopia charting is that whether the images are crossed or uncrossed. That itself gives you lots of information. And usually it is red in front of the right eye and green in front of the left eye. That too you have to document. And how the images are separated, whether it's a horizontal separation or whether it's a vertical, oblique or a combination. And also the things that you can get from a double vision, the informations are where the maximum separation of images is occurring, in which box. And then you should think of the yoke muscle in that particular direction. So you should have an idea of which are the muscles which are acting in those particular direction. So when you come, just look at the box which has maximum deviation, and then you know that mainly it is the 2 muscles, and from that you have to find out which muscle and the corresponding nerve. And always the outermost image will belong to the affected eye, and horizontal uncrossed images, usually the lateral rectus is involved, and crossed it is medial rectus. And these are the few tips, like in vertical diplopia, when you have uncrossed, usually the obliques crossed vertical, and tilt to the sound side in superior, when superiors are involved, and tilt to affected side the inferior. And the HES charts and rescreen we are not using nowadays much, but they are helpful for documentation. And systemic evaluation is extremely important. Like if you have a diabetes, hypertension, etc., you have to rule out all this, and lid changes, thyroid association which can cause committance strabismus, committant double visions, myasthenias, inflammations, and other cranial nerve examination. And the red signals for neuroimaging are younger age of presentation, multiple cranial nerve involvement, recurrent cranial nerve neuropathy, evidence of increased intracranial pressure, and aberrant regeneration if no imaging was done earlier, and no improvement in 6 weeks in double vision when they are associated with a systemic condition and trauma. So double vision assessment prerequisite, patient and examiner should be patient, and proper understanding of extraocular muscle functions and nerve supply, documentation and neuroimaging when and where needed. Thank you.
Thank you, Dr. Meena, for that exhaustive diagnostic techniques for a patient who comes with double vision. Now we move on to Dr. Sumita Agarkar. Often we face children with unexplained vision loss. How do we go about these patients, these children? Over to Dr. Sumita Agarkar.
Good morning, and thank you, Dr. Leila, for considering me. I am not a neuroophthalmologist. I am a pediatric ophthalmologist, so feel free to correct me. There is a bit of overlap. So how do you define unexplained visual loss? So it is a visual impairment that occurs out of proportion or in absence of any objective ophthalmological findings, and it can be unilateral or bilateral. But usually when we look at children in the clinic with unexplained visual loss, our first thought is uncooperative, second thought is malingering, but really these are the last, should be the last on your mind. Children may not tell much, but when they say, okay, I don't see well, you should believe them most of the time. So when you look at the unexplained visual loss, always think of horses versus zebras. It could be an uncommon sign of a very common disease, or it could be a common sign of a rare disease. So both exist. So let's look at a case, this 4-year-old male child who has come with both eyes poor vision, but right eye low vision noted by the parents, a little outward deviation of the right eye. No history of any of these things, perinatal period uneventful, normal developmental milestone. Visual acuity is 2/60 and 6/18. This is his refraction. Has some definitely RXT. Ocular movements are full, anterior segment normal, and these are his fundus pictures, which doesn't look anything majorly abnormal. We gave glasses, part-time occlusion of the left eye, but what I don't like is that he's still 6/18 in the left eye, where I can explain 6/60 in the right eye with that exotropia. But 6/18 OS, a child who has been wearing glasses, no major things, compliance to glasses patching good. So this time we check color vision, which is not really, we check it every time. And now he reads only a test plate. So we do a fundus photo with AF, and you can see there is a macular dystrophy there, which is beginning, which is not visible on his fundus pictures if you remember last. This is his ERG, not a very good recording, but because he was not very cooperative, but you can definitely see the pattern of reduced scotopic and photopic response. I need to repeat it at some point, but we know that vision is, we are dealing with some kind of retinal dystrophy here and not just astigmatism or exotropia. So workup in an unexplained visual loss is nothing great. It means only these 4 points: a good comprehensive history, a comprehensive ophthalmic examination which is not directed towards symptomatic checkup, proper selection of ancillary diagnostic tests, and last and foremost what we call as gut feeling, or basically red flags and high index of suspicion where you need to see. So good history is irreplaceable, and history should include all these points: history of consanguinity, family history of first degree relatives of poor vision and nystagmus. This is often not volunteered, but if you ask, you might get the history, and that almost tells you the diagnosis straight away. Similarly, history regarding symptoms which may not be volunteered are photophobia and night blindness, which unless you ask a guided question, they are not going to tell you. So comprehensive ophthalmic examination means eye exam which you do it in a textbook. Visual acuity, definitely do not take every attempt to do a visual acuity, both eyes. Interocular visual acuity difference is more worrisome than poor vision in both the eyes. If one eye is 3/60 and other eye is 6/18, I will worry about that. I will not worry about 6/12 OU both eyes. Color vision, very important part if you are looking at unexplained visual loss. Cover test, madam has already alluded to sensory examination, and I don't want to go into detail. Pupils, again, very, very important sign, and we all forget because we let our optometrist check it. But if it's unexplained, next time, please do it yourself. A cycloplegic refraction and a dilated fundus evaluation. Diagnostics which help you: neuroimaging, imaging, like I said, autofluorescence imaging, photographs sometimes, electrodiagnostics, VEP and ERG, irreplaceable, visual field examination. Even if child is uncooperative, you can definitely do a confrontation test, and OCTs and many other evaluations which are now available. So this is a comprehensive list of things which can appear as if they are unexplained visual losses. When I say normal looking eye, it is just that they are in an earlier stage of their disease, that you don't pick it up, you don't see it, it's not staring at your face, or things may be subtle and you will see them only if you look for them. So this is a comprehensive list where children can present with unexplained visual loss. So what are transient amyloidogenic factors? These are some during infancy or early age. They might have any of these things: a lid swelling, a macular hemorrhage, a transient strabismus, vitreous hemorrhage, which has gone away but has left the child with some deficit from that time, and often these children are monofixators. So next thing which you have to look for is monofixation syndrome. So this is basically facultative scotoma. You may have a unilateral slightly poor vision, or maybe densely poor vision. There is often subnormal stereo acuity, retained peripheral fusion. And the diagnostic test for looking for this kind of suppression or monofixation is to do a 4-prism base out test. So you can look at this history. 11-year-old, again 6/24, he is slightly anisometropic myope, orthophoric, but does not explain despite patching. Vision 6/24, vision stereo is 200 arc seconds, anterior segment fundus examination look normal. Refraction does show a little bit of anisometropia, and this is how you will do a 4-prism base out test. So right eye is a non-fixing eye. So when you place the prism over his right eye, you don't see any movement, but when you stay, you can see that slight flick divergence with no refixational saccade, which should happen. So this vergence movement in one eye when you place the prism over normal eye, and no movement when you place the prism on poor eye, is what it shows you that there is a monofixation. It does not tell you microtropia, it tells you that patient has suppression scotoma in that eye. So this is also very, very important test when you are looking for if child is monofixator, where there are not obvious anisometropia, strabismus. You can still demonstrate that child can be amblyopic. Now refractive errors, sometimes ametropic amblyopia, meridional amblyopia, they all can come as slightly impaired visual acuity without, and a lot of these will improve with glasses and patching sometimes occasionally. So this must be again looked for, and they can also appear as if normal visual. So a small tip here and a learning lesson here. This is a 4-year-old routine exam because he is a sibling of one of his brother who has a refractive accommodative esotropia, and this is his refraction. He is ICS on cover test. I give him glasses, full correction, patch right eye, follow-up visit, he is orthophoric with glasses, vision 6/12, refuses to budge. 2.5 years go by, now he is 8, visual acuity is still same. And now I actually put a minus 0.75 diopter over his glasses, and lo and behold, visual acuity improves. So some of these children who have been wearing hypermetropic glasses for a while and vision doesn't improve, maybe a year or down the line, you should probably look at, they might, and when they are a little older, they might do a little better with a slightly under-corrected hypermetropia rather than the full corrections which we tend to give in these situations like here. So amblyopia, of course, I don't need to go in detail, but here also visual acuity is equal, and you have to look for small signs, subtle signs for exotropia, anisometropia, and other monofixation. So coming to keratoconus, again, early keratoconus may just present as high cylinder and not improving vision. Clinical signs which we read classically of Vox dry and all may not be present at all. But we have to keep a high index of suspicion in patients who are eye rubbers or who have atopic disease or have Down syndrome. Scissoring reflex on retinoscopy is a giveaway. Topography is diagnostic, and contact lenses almost improves vision fully in these patients, and you should probably ask for a RGP lens trial rather than a soft lens. Juvenile open glaucoma, steroid-induced glaucoma, post-traumatic glaucomas also can present only as progressive myopia in older children, and when in the presence of myopia, sometimes it's difficult to assess the disc, and intraocular pressure must be checked in these situations. Disc evaluation, difficult sometimes because of coexisting myopia, but you must make an attempt to look at the disc. Often these children with advanced glaucomas have more pallor than cupping, and this finding must be noted. You should do a gonioscopy. This kind of gonioscopy with fulminant iris process is 360 degree often points towards juvenile open angle glaucoma. And of course, I don't want to go into great detail about how to manage glaucoma, but this is also something you should look, because we don't check intraocular pressure routinely in children. So you should do it if it is progressive myopia and no improving vision. Sometimes subluxated lenses. This child, if you see him without dilatation or poor dilation, you will miss this subluxation. Visual acuity is not improving because there is bilateral subtle subluxation of the lenses. Of course, now when you have seen the subluxated lenses, you will see tall stature and everything else, and then you will ask the history, and yes, father also has bilateral aphakia with retinal detachment, but here don't rush in to do SFIUL, plus first do a good refraction and give them glasses. They often always improve with glasses. Retinal pathology, retinal dystrophies, they are also one very large group of patients where there is unexplained visual loss. What are the red flags? Where do you suspect retinal dystrophies? Visual loss, high or even moderate myopia, hyperopia, subtle nystagmus, a normal fundus, often normal fundus. This does not rule out retinal dystrophies, and poor color vision, and family history of first degree relatives having any of these symptoms or actual visual loss. So these are something which you will get only in the history and not volunteered. Can I have 2 minutes? So this is a patient, again 13-year-old, normal looking fundus. But when you do her AF, you can see that there is a macular pathology, and we do ERG, which is normal because it's just macular pathology. But look at multifocal ERG, which is showing a clear depressed response at the macula. OCT shows thinning, and when we do genetic testing, it is suggestive of achromatopsia, and you can see father has mutation, and you're out. You change. You don't look at -9 there. Don't go for atropine here. Look for why she is not improving vision. This is another case. This is the history. This is his refraction. Anterior segment looks normal. Posterior segment looks also on and obviously normal. There are some lattices, but otherwise normal. But look at his ERG. A classic negative waveform on suggestive of complete CSNB, a decreased rod response, and nearly normal cone responses. So these are all the retinal dystrophies which can present with normal looking fundus, especially in children. In adults, when they see them, you will have clinical features, but in children, they will have normal fundus. So these are your red flags for looking at retinal dystrophies. Now coming to neurological neurodevelopmental issues, all of these can often have subtle signs and you may miss it. Optic neuritis, especially if it's retrobulbar and symmetrical, you may miss it. Leber's optic heritage, again here history is important. So this is 7-year-old, treated for vision dropped suddenly, and color vision again here is a very important sign. RAPD is not gross here, it is trace, and if you would miss it if you don't look for it. But if you look at his fundus, this is his fundus. There is no edema, no nothing, but vision is 2/60, and this is where you should look at neuritis as a bilateral involvement in children is very common, and you should look for it. This is his VEP. MRI showed definitely, and MOG antibodies were positive. He received IVMP and did improve vision in both eyes with appropriate treatment. Supracellular tumors can sometimes present as very subtle disc pallor. 15-year-old, 7 months history, has a small RXT but poor vision. If you look at her fundus, when I tell you after the history, you will see there is a pallor in the right eye, but if you miss it in a busy OPD, you might say there is discs are looking normal. There is no papilledema or anything. These are her fields because she is older, and MRI was sure enough was suggestive of craniopharyngioma. CVI, again a big group where patients can have very little signs in the eye. In fact, optic nerves almost always are normal and strongly associated with prematurity, hypoxia, sepsis, neonatal, eventful perinatal period, and history will point to the diagnosis here. So mechanism of injury is this, and you can see periventricular leukomalacia if you do an MRI. An MRI should be warranted at least to document what is the reason. So spectrum can be ranging from mild to severe. You can have motor involvement, you can have CP-like picture, you can have absolutely normal high functioning CVIs also. Optic nerves almost always look normal, or there may be a subtle pallor, but there are overt neurological issues almost always. So neuroimaging is essential. VEP is easy and non-invasive, but may not be very informative if you are looking at CVI. So these are the causes, and if you have ruled out all of them, then you have to look at functional visual loss or malingering as the last diagnosis. And here you have to have some stressor which is, or some gain which is to be gained. Children often don't have gain, but they can have stress points which they have, and this is a battery of tests to look at. Simple tests like madam mentioned, stereopsis. If stereopsis is good and he is saying I can't see anything, you know this is not possible. Similarly, looking at fogging or simple plus minus combination of glasses, if you put, lot of times children will read it. So some of these tests you can do very easily in the clinic in 5 minutes, like for fogging, start with +10 and go on reducing till he becomes 0 and then he starts reading. That's a very simple test. But there are some children who are very hard to crack, and if there are real functional issues there, first rule out everything organic by doing appropriate testing, even though you think it is important in children not to miss things, as I showed in so many things. So do all the tests, but once it is there, probably you need a multi-speciality or a more professional approach to children who are having functional visual loss due to something which is triggering or so disclosing to family and patient. Probably it is beyond our call here, and you should let a professional handle these children. Thank you very much for your attention.
Thank you, Dr. Sumita. You have to go back.
Yeah, and I can take question.
So I think for now we'll have 2 or 3 questions now and then proceed with the next. Any questions from the audience?
Madam, how long do you wait for the refractive adaptation? Like some children, they don't improve beyond 618, 624.
You know from the type of refractive error, a child who is anisomyopic, refractive adaptation is just around 6 weeks. They will improve in 6 weeks. But child who is wearing +6 for the first time, you have to give a little longer time, maybe 4 months. I will still wait for pushing on if everything clinical examination is absolutely normal, history doesn't point to anything. I don't see anything like ocular digital reflex, wandering nystagmus, and vision is 618. I will still give it a year for plus hypermetropia. Okay. Astigmatism also I will give around 6 months. But if they are not improving beyond that, then probably yes, you should probably look at. First thing is to go back to the patient as a new patient. Look at it, everything back again, and then probably press the panic button about investigations. We are so sure about our findings, we never look back at it. I have missed disc pallors several times. So if it doesn't match, if you think that this cannot cause amblyopia, don't label it as amblyopia. Amblyopia doesn't behave that way. Seek second opinion. Sometimes somebody sees it with a fresh eyes.
Yeah, true.
You pick up findings.
Better to say.
After treating refractive errors for a long time, like for 1 year, 2 year, even after giving citicoline and all, if the patient is reaching up to 612 and 69 OU, both the eyes,
I won't worry about that. A lot of those patients, if you watch them till they are teenagers, they will become 6'6".
Then we need not to do.
But yeah, rule out everything else.
But then parents are like, why they are not?
That's what I said. I will worry about unequal vision. I won't worry about 612.
Thank you.
If everything is okay, all riders are, everything else is okay.
Also, there is this tendency for labeling patients as bilateral amblyopias and then patching alternate. I have never found that to be at all helpful. As I completely agree with you, Sumati, that I would just leave these children alone and let them grow into 6'9" or 6'6". But I get patients with bilateral and they are miserable because kids don't like a patch, and patching each eye one day this, one day that really doesn't help.
When you work in the same institute, you see the vision improving, like it improves with time. When other things are normal.
In my early ages, when I was younger, I used to give alternate patching. I won't disagree with. The question is valid. When I was that young, and I used to sometimes really stress patients ki vision is not improving, especially high astigmats who have -4 astigmatism both eyes. They will move to 612 +2 and then kind of stop there. And so I think you have to just reassure the parents that over a period of time it will come to 6'6" part, and it will not interfere with their educational or career choices. I think that little bit of chair time is required. I still give alternate patching, though I agree with him, but sometimes if parents feel that we are not doing anything, if they seriously are coming from Bihar and kuch nahi. Okay, do alternate patch, do some vision therapy. But honestly, I also know that.
Okay. Thank you, Dr. Sumita, for that wonderful talk. So
now I invite Dr. Nina from Giridhar Eye Institute to speak on the patient with internuclear and supranuclear disorders and of ocular motility.
Thank you, Dr. Leila and AOS, for this opportunity. So we've seen, as ophthalmologists, we're all familiar with the ocular movements, and Dr. Meena has wonderfully explained how we should look at the ocular movements as well as how we should diagnose diplopia. Now, we're all familiar with these kind of ocular movements, so ductions, versions, vergences. So I'm going to talk about from the neurophthalmic perspective. So we know that there are extraocular muscles and the nerves which control them. But how many of us know that there is a 3-level control of eye movements? So we have a supranuclear control of eye movements, which means we have the cortex, thalamus and cerebellum controlling the eye movements. Then we have the nuclear pathway, that is the nuclei of the 3, 4, 6 cranial nerves, and the internuclear pathways. And then of course the intranuclear pathways, which constitutes the nerves and the extraocular muscles. So from this point of view, I'd like to classify the movements as fast ocular movements like saccades and slow ocular movements like pursuits or optokinetic nystagmus, vestibular ocular reflex and divergences, or as gaze shifting or gaze holding. So what's the purpose of all this? It's basically to focus the image onto the fovea and to keep the track of the image as the observer moves or as the target moves. So basically all eye movements and all these control is to get a good image of the object and to keep it tracked onto the fovea. So let's look at each of this. It seems complicated, but it is not so. So I'll be talking from this neurophthalmic perspective. Let's look at the gazes. So we have horizontal gazes and vertical gazes. So this all looks very complicated now, but the thing to remember is that there is a common final pathway for horizontal gaze and a common pathway for vertical gaze, but the centers are separate for horizontal gaze and separate for vertical gaze. So I'll come to that. Just a bit of anatomy. So horizontal eye movement, the important thing to remember is the center is in pons, pontine tegmentum. So you look at here, you have a PPRF or paramedian pontine reticular formation and the 6th nerve nucleus, and from there the command goes to the same side at lateral rectus to the 6th nerve nucleus, and the 6th nerve nucleus, it talks to the 3rd nerve via a channel known as the medial longitudinal fasciculus, and a conjugate movement is made. So the lateral rectus on one side and the contralateral medial rectus contracts and you have a conjugate movement to one side. This is your horizontal gaze. Now how does this happen? So for that, let's look at this video. So I'm going to talk about from saccades and pursuits. So to understand what is a saccade, so this is a horizontal saccade which is generated. They are fast eye movements in which you are asked to quickly move your fixation from one object to the another across this. This is a horizontal saccade between the across the horizontal eye field. So where does the command come from? It comes from the contralateral frontal eye field. Suppose you want to look to the left, the command comes from the right frontal eye field. It crosses over, comes to the opposite PPRF and 6th nerve nucleus, and from there the 6th nerve nucleus gives command to the lateral rectus to the move, and also it also tells the opposite medial rectus to move via the MLF. So that's how a conjugate movement to the left happens through your right frontal eye field command. So this is the pathway for the horizontal saccade. And now coming to pursuits. Remember P for pursuit. So posterior parietal cortex is basically responsible for your pursuits. Ipsilateral posterior parietal cortex. Again, the horizontal gaze center is in the pons. So PPRF and 6th nerve nucleus. The same pathway via the MLF to the contralateral 3rd nerve nucleus, and you get a. So this is the pursuit happening. It's a slow tracking movement. You're following the object very slowly around the horizontal eye field. Now coming to the vertical gaze center. So vertical gaze center is different. It's in the midbrain at the thalamo-mesencephalic junction. You have two important nuclei. If it's difficult, forget about it. The rostral interstitial MLF and the interstitial nucleus of Cajal. And important thing is the final pathways to the cranial nerves 3 and 4, which make the upward and downward movement. So let's see some videos. Thing to remember is vertical gaze center is in the midbrain. So let's look at this video. So to initiate vertical saccades, you need firing from both frontal eye fields, because saccades are generated from the frontal eye field. So again, from both frontal eye fields fire, and the command goes to the midbrain here because it's a vertical gaze. So rostral interstitial MLF and nucleus of Cajal and the neurons of the 3rd and 4th nerve nucleus, because it's vertical eye movements, they act and you get a vertical eye movement. Now coming to the pursuits, it is similar, slow tracking movements of an object held across the vertical eye field. But remember P for P, it comes from ipsilateral posterior parietal cortex, but the center, because it's a vertical gaze, is in the midbrain, rostral interstitial MLF and Cajal, interstitial nucleus of Cajal, again through 3rd and 4th nerves. So there are a lot of complicated things here. You have torsional saccades also. If you want, you can look into it, but I'm not telling it to confuse you. Let's look at vergences. We always forget vergences when we examine patients. Please remember, it's very important. They are disconjugate movements in opposite directions. What does it do? It allows bifoveal fixation of an object. So accommodative vergence happens when you have a retinal blur, whereas the location disparity of an image gives you the stimulus for a fusional vergence. Now, the vergence centers are multiple, not exactly known, but you have centers in the occipital cortex area 19 and 22, in the midbrain, reticular formation, even in the pons, and the command goes to the 3rd and 6th nerve nucleus. So there is reciprocal activation and inhibition of medial rectus and lateral rectus muscles, which allows you to converge as well as to diverge, depending on what vergence you're doing. So After that, now we come to the vestibulo-ocular reflex. Now these act like peripheral controls of the horizontal and vertical gazes. What does it mean? Simple thing is, when you move your head to one side, eyes will move to the opposite direction. This is a very primitive reflex so that the object is always tracked. So what does it do? It keeps the image focused and holds the head steady, and it's also known as the doll's eye movement or the oculocephalic reflex. How does it happen? So when you move your head to one side, the same sided horizontal semicircular canal is stimulated, vestibular nucleus is stimulated, command goes to the opposite abducent nucleus, to the same sided lateral rectus via the MLF to the contralateral medial rectus, and a conjugate movement to the opposite side happens. So this is the basic pathway. Now, coming to the optokinetic reflex, it is also an important reflex. It allows us to track a moving object with our eyes, and an intact, you need an intact visual pathway for this. Cerebellum has an important role. It's a master modulator. It fine-tunes all your eye movements, and you can see in this picture it has connections to all the important centers. So that's where you get abnormalities of gaze and saccades in cerebellar lesions. So let's come to some of these disorders. So basically, supranuclear lesions will produce gaze palsies, gaze deviations, saccadic pursuit disorders, vergence abnormalities, skew deviations, nystagmus, and ocular oscillations. So I won't go into all. I'll just touch upon a few. So let's look at some of these. Some of you will be asked to look into these when you have a multi-speciality practice. So let's look at this. So this lady, you can see, has very sick. She's in the ICU, but she has a gaze. Her eyes are deviated to the left. So she has an irritative lesion of the right frontal lobe. So irritative lesion of the right frontal lobe will make the patient look towards the opposite side. So as in this case, like a seizure, or if you have a paralytic lesion of the frontal lobe, you cannot look to the opposite side because the contralateral frontal eye field helps you to look to the opposite side. So here the patient, in this video, patient cannot look to the opposite side, or patient looks towards the lesion of an other side of the brain. So these are some, conditions in which you may be helpful in diagnosing where the lesion is. What if you have a homonymous hemianopia, which is very difficult for you to distinguish? It's a parietal lobe lesion or occipital lobe lesion. How do you distinguish? Look at the pursuits. If the ipsilateral pursuits are intact, it's unlikely to be a parietal lobe lesion because parietal lobe is responsible for the pursuits. Whereas occipital lobe lesions, it will be intact. So coming to horizontal gaze palsy, I want you to listen carefully because this is very important to distinguish from a sixth nerve palsy. In a sixth nerve palsy, you have only the fascicular part which is involved, so you only have a abduction limitation, whereas in a horizontal gaze palsy, you have a limitation of abduction of one eye and adduction of other eye. So it can occur anywhere in the lesion of PPRF as well as the sixth nerve nucleus. So that is the key here. Both can produce a horizontal gaze palsy. And coming to INO, we know INO is due to a lesion in the medial longitudinal fasciculus. Why does this happen? Because the sixth nerve cannot talk to the third nerve. So there is loss of adduction of the involved eye. So that is typical INO. Let's look at some features. So this patient has wall-eyed binocular internuclear ophthalmoplegia. He has exotropia. And if you look, you can see carefully that his adduction in the right eye is limited with an abducting nystagmus of the left eye, and the same happens in the other eye. So some of them will have normal convergence, especially if it's a posterior INO. If it's an anterior INO, convergence may be lost. So there are so many other features. I'm not going to go into it. Important thing is, in a young patient, think about multiple sclerosis. An older patient, think about a stroke. So 1.5 syndrome, a lesion of the PPRF and the MLF of same side. Then vertical gaze palsies, you have Parinaud's dorsal midbrain, progressive supranuclear and monocular elevation defect. Parinaud's classical triad, upgaze palsy, convergence, retraction, nystagmus, and light near dissociation. And this is all because of loss of inhibitory control of this third nerve nuclei, which is present at the level of the dorsal midbrain. And here you can see that, just take a minute, you can see that this patient is not able to look up. She has upgaze palsy from hydrocephalus, and PSP is another condition which comes to you, and you may be the one who might distinguish PSP from Parkinson's, because in Parkinson's disease they don't have downgaze problems, whereas here you can see this lady has PSP, which is a very worse form of Parkinson's disease with downgaze difficulty, and this MRI will show a hummingbird sign or a Mickey Mouse sign. And Parkinson's patient also will come to you with difficulty in convergence and double vision. So this is because convergence is one of the first things to go in Parkinson's, and they have difficulty in reading, and you may give them prisms, and that may be helpful in the initial period. So how do you know whether it's a supranuclear or a nuclear lesion? Just do an oculocephalic reflex. So if the oculocephalic reflex is intact, it is supranuclear. It's because, because what I've explained now. So I'm skipping all this due to lack of time. I'll just go to one last slide. So can anybody tell me what this is? So this child has a very peculiar head position. See how he is able to, when I'm giving him another toy, how he fixates or how he shifts his gaze. So when I ask him to look at a toy, see, instead of making a saccade, he puts a head thrust. This is classical oculomotor apraxia, and the parents told he's got a funny head position and he had Joubert syndrome because of the superior cerebellar peduncle molar tooth sign, superior cerebellar peduncle involvement. So the important thing is, checks, as ophthalmologists, we can always have the luxury of checking saccades, pursuits, and divergences, and remember to distinguish between nuclear, infranuclear, and supranuclear lesions. Remember that horizontal gaze center is in the pons and vertical center is in the midbrain, and vestibular ocular reflex is preserved in supranuclear lesions. And most of the supranuclear lesions don't produce diplopia unless you have a skew or asymmetric involvement. Thank you very much.
Thank you, Nina, for that excellent talk. However much you here get confused about the anatomy. The next speaker is Dr. Leila Mohan. Madam is a senior pediatric ophthalmologist and cataract surgeon and at Comtrist Hospital, Calicut. She'll be talking on investigating pale disc in a child.
Now, coming to the another dilemma, when you have a pale disc, you want to know whether it is genuinely pale or not. So pallor is a morphological sequel of damage to retinal ganglion cell and axons along their course from retina to lateral geniculate body. It's due to the loss of ganglion cell axons, reduced vascularity, gliotic proliferation, increased visibility of sclera, and there is an overall reduction in size of the optic nerve. And retrograde axonal regeneration in posterior visual pathway due to perinatal trauma can also lead to pallor. About 30% of children with multiple disabilities like CP, motor developmental delay, they have pale discs. And pathology may be degenerative, ischemic, inflammatory, traumatic, demyelinative, or compressive. Optic neuropathy is a better term than atrophy. The causative factors have changed over the last 50 years due to diagnostic challenges accounted for not finding a causative factor in a good number of cases before the advent of the investigative imaging modalities. And in the 60s, it was inherited conditions was considered to be the commonest. In the 80s, brain tumors, and now complications of premature birth and perinatal insults account for a good number of these cases. So a good workup, visual acuity, field, color vision when possible. Signs and symptoms of visual loss including field is not easy to elicit in a very young child, and methodical clinical examination including a family history of similar vision loss, including a pedigree chart, birth history, pre, post and perinatal insults, seizures, hypoxia, developmental history, trauma, exposure to medications or toxins are all important. And pupil, examination of pupil is very important. OCT of the disc and retina can point out the distribution of loss of RNFL, whether it is progressive over time. FFA and autofluorescence and electrophysiological tests rule out any retinal pathology, and neurological evaluation with VEP and of course MRI. So coming to the examination of the disc, the shades and distribution of optic disc pallor are to be noted. As you see here, you can see temporal pallor which may point to a hereditary or nutritional deficiency or a post-neurotic pallor, and peripapillary indistinct margins and gliotic tissue may point to a chronic papilledema, and bow tie pattern as in chiasmal or post-chiasmal lesions, and consecutive optic atrophy. You have to look for any retinal nerve fiber dropout and thinning, and attenuation of blood vessels around the disc has to be noted. Some of the mimickers are myelinated nerve fibers, As you see here, optic disc coloboma, optic disc hypoplasia with a double ring appearing like a pale disc. Buried drusen is not uncommon. You have to rule it out with an autofluorescence. Sometimes even a bright light pressure on the eyes can appear as a pale disc, so the child has to be brought back again to see, especially during infancy when you forcibly open the eyes. So let us go through some of these scenarios. We cannot go through all the conditions of pale disc. So a 2-year boy with motor disabilities was referred by pediatrician for defective vision. He was fixing and following with both eyes not reaching out yet and showed pale discs. His history of prematurity and perinatal admission in the ICU and global developmental delay and seizures was there with spasticity. MRI showed volume loss and hyperintensities in periventricular white matter, as you see in this picture, and was diagnosed with periventricular leukomalacia. Hypoxic ischemic encephalopathy can produce atrophic, cystic and gliotic changes also. Functional vision assessment is important in these cases, and vision improves to a great extent over time, and early rehabilitation with a multidisciplinary approach is necessary. And this is an 8-year-old boy with complaints of defective vision, tripping over when walking and poor performance at school. You can see the large cup, and he gave a history of the parents gave a history of prolonged neonate NICU management, and visual acuity was 618 with a cylindrical correction of -180, which is not very high, and a cupping was of 0.8 in both eyes with a large disc. IOP was normal. The field showed bilateral inferior altitudinal defects, and MRI showed PVL, periventricular leukomalacia with occipital gliosis, and prenatal injury to the optic radiations with retrograde transsynaptic degeneration of retinogeniculate axons produces this picture, which was described by Jacobson in 1995. We can avoid unnecessary examination under anesthesias to rule out glaucoma in a child when this presentation happens with a very large cup, and it's not uncommon to see these due to perinatal trauma. So a 16-year-old boy, I used to do a lot of examination under anesthesias about 25 years back to rule out some of these cases, but over time you follow up, you see all these findings with an inferior altitudinal field defect. So a 16-year-old boy of studying in +1 complained of blurry vision in right eye, which was progressive over 3 days, and visual acuity was 660, 690. Refraction was normal, pupils were normal. Fundus showed mild hyperemia of the disc. Color vision was abnormal with the desaturation. Field showed centrocecal scotoma in right eye. VEP showed delayed latency, and MRI was normal. So we diagnosed optic neuritis and started him on injection. This was some time back. Injection methylprednisolone followed by oral prednisolone. After 2 weeks, vision in left eye also became blurred. And when he was on steroids, vision came down to 5/60, and it was progressive over 3 to 4 weeks. Both eyes had 360, 260. On further inquiry, many members in the family from maternal side had defective vision, the cause of which was not known. The discs showed pallor and pupils became ill-sustained. We suspected LHON, Leber's hereditary optic neuropathy, and had a neuro and cardiac evaluation. He did his exams with the help of a scribe for 2 years, and after this his vision recovered to a great extent. Vision improved to 6/9, which is very unusual in these cases. So a molecular analysis was done later, which showed 4 mutations, which as you can see here, all these numbers, 4 mutations on ND1, 4 and 6 are not the usual pattern we see in LHON. So this Leber's hereditary optic neuropathy is inherited through maternal mitochondrial DNA due to primary mutation of one of the 3 mitochondrial DNAs, and these 3 account for 90% of the cases. They present with acute drop in vision in about 2nd or 3rd decade, more in males, and progressing to optic atrophy and permanent and profound vision lost in most of the cases. Some patients with who had an early onset may recover, and they may have associated cardiac neurological when they are called Leber's plus. Now, Idebenone, ubiquinone analog which supports mitochondrial ATP synthesis and has an antioxidant property, is recommended since 2017 with reasonably good results when started early enough and even up to 1 year. And gene therapy and stem cell therapy are on trial. Other medicines on trial are brimonidine, glutathione, antioxidants, all to protect the mitochondrial DNA. Genetic counseling of the predisposed to avoid neurotoxic agents. These are triggered by some of the neurotoxins. So to avoid tobacco, alcohol, and ethambutol, which to prevent the triggering of the predisposed patients. Other forms of hereditary optic atrophy are also there. Autosomal dominant mitochondrial dysfunction with an OPA1 gene mutation, and slow, which has a slow onset during first decade and slow progression. Often they are brought during school screening, and they have central or centrocecal scotomas. Neurological associations may be seen, and idebenone has been tried, and with some good results. X-linked and recessive forms of optic atrophy are also seen, and Wolfram syndrome is a recessive condition with childhood IDDM, insulin dependent, and diabetes mellitus with optic atrophy and deafness. So molecular analysis is sometimes important in these cases. So a boy of 4 years was admitted in neurosurgery department with following RTA. We were called to see the eye. He showed RAPD in right eye, vision was only counting fingers, and fundus appeared normal, and traumatic optic neuropathy was suspected and taken up for decompression of the fracture, and injection methylprednisolone followed by oral steroids started. Vision improved to 636 and then stayed there. Was advised patching but did not improve further. Later he developed exotropia, which was corrected later. So traumatic optic neuropathy is sometimes another condition where you have to look for the fundus very carefully and look for any RAPD. So this is an 8-year-old child who was being followed up after a unilateral cataract surgery with amblyopia. Later we found that her vision was dropping. She was not very compliant with patching, but we on a disc appeared pale, so we did vision was down below a few meters, so we couldn't do a field test in that eye. But when we did field testing, the other eye showed hemianopia, and a large solid cystic mass was seen. So these are some of the cases which you might miss when you look at especially in a phakic eye. Looking at the disc may not be very convincing that it is pale. And this child, 14-year-old, actually after a fall he had an investigation of vision, and vision was half meter. Disc showed a temporal pallor, but other eye showed hemianopia, and MRI showed multicystic lesion with calcification pointing to a craniopharyngioma. He was operated on. And these are some of the tumors of childhood. And compressive lesions are also not uncommon. You have to follow up these patients for any compression and optic nerve dysfunction, and surgical intervention may be necessary. This is not an uncommon situation where there is a diffuse unilateral subacute neuroretinitis with a fundus showing thinning of the arteries, arterial attenuation, marked chorioretinal changes, and a motile nematode may be seen on fundus examination, which may respond to laser treatment. And nutritional optic atrophy occasionally, especially in an autistic child who has a stereotyped diet, sometimes present with the pallor. And pediatric optic neuritis we have already seen. A detailed history, field examination, and look for RAPD. Field examination is very, very informative sometimes. Imaging and molecular analysis in selected cases, and a high index of suspicion and imaging whenever necessary. Thank you. I'm sorry for taking one.
Thank you, ma'am, for that very illustrative talk. I call upon Dr. Ruhi M. to talk on anisocoria. She's from Comtist Eye Hospital, Calicut.
A very good morning to one and all present here. Thank you, Dr. Leila ma'am and AIOS for this wonderful opportunity. I would like to speak on an approach to anisocoria. Anisocoria, in layman's term, means the presence of difference in the size of the right and the left pupils. It is a sign of an abnormality in the efferent pathway. If you suspect anisocoria, first step is to take a thorough history. And the second step is to ask the following questions to yourself. First question is there anisocoria? And the second, is the smaller or the larger pupil abnormal? First of all, what is the normal pupil size? It is up to from 2 to 6 mm. Ordinarily, we see 3 to 4 mm diameter. Physiological anisocoria, there is about 1 mm difference in up to 15 to 20% of the normal population. A difference of 2 mm is considered significant. This is the parasympathetic pathway, as you all know. It is usually affected in third cranial nerve palsy, tonic pupil, and uncal herniation. Sympathetic pathway, as you all know, this is the pathway, you all already know about it. It is affected in Horner syndrome and pontine hemorrhage, to name a few. So the near response is an interplay between convergence, accommodation, and meiosis. First and foremost, take a history, as was clearly pointed out by all of these eminent experts. Blurring, amaurosis, double vision, headache, numbness, face, neck, arm pain, a trauma or surgery, exposure to toxins or drugs, systemic diseases, and most importantly, old photos need to be checked. A thorough visual examination of visual acuity, color vision, lid, proptosis, extraocular movements, visual field analysis, at least a confrontation test, cranial nerve examination, and of course check for superficial temporal arteries in the hands, necks. So a pupil examination, we can use a pupil gauge to measure. We need to check the size of the pupil in light, in ambient light and in dark. We need to check size of pupil after about 20 minutes of sitting in a dark room, called the dark adaptation time, and then in a well lit room. Check the light reflex, the near reflex, and swinging flashlight test is a must. So this is the algorithm. I will take you through each of this, but in general, if the pupil size is equal, check for RAPD, and if there is anisocoria, check for physiological, or if it is pathological, check if there is any damage to the iris, if there is any sympathetic or parasympathetic defect. So these are the causes of a large and a small pupil. You all know it already. Anisocoria is physiological, as you all know. But what is important is there is good reaction to light and dark. The lids and extraocular movements are normal and may change size and side. So anisocoria, we need to check if it is worse in darkness or similar in dark and light, or worse in light. This is the basic algorithm that I'll take you through each case. The first case, a 27-year-old male, he presented with headache and a blurring of vision. The right eye pupil, as you can see, there is a difference in the size of the pupils between the right and the left eye. This was the left eye. As you can see, a vermiform movement of the iris. So let us take you through. Do both the pupils constrict to light? They did not. So was the larger pupil abnormal? Was there ptosis or abnormal extraocular movements? There was not. So was there vermiform movement? Yes. So we can consider if it is AD stonic pupil. So we tested with pilocarpine 0.125% and there was constriction of pupil. So we gave a provisional diagnosis of an AD stonic pupil. The second case, a 24-year-old female with history of RTA, road traffic accident, 3 days back. She had a complaint of diplopia. On examination, she had adduction and depression limitation, and the pupil was dilated in the left eye. I hope it is clear in the image. So here we checked again, was the larger pupil abnormal? If yes, then there was ptosis and abnormal extraocular movement. And so we considered a third nerve palsy. An MRI was suggestive of a diffuse axonal injury of the left side, and other clinical symptoms pointed to a diagnosis of an incomplete third nerve palsy. The third case presented with ptosis, meiosis, and anhidrosis. This is a video taken from the web. As you can see, there is a dilatation lag along with meiosis and an anisocoria more than 2 mm. In some cases, there is difference in eye color, difference in pupil size, or impaired facial flushing. 1% apraclonidine test, we can see there is lid retraction with dilatation of pupil on the affected side. These signs, along with other signs of Horner syndrome, give us a diagnosis of Horner syndrome. Theoretically, we also need to know about the effect of cocaine. So, cocaine, on instilling 2 drops of cocaine, 4% and 10%, in each eye, 5 minutes apart, and then measuring the degree of anisocoria. A post-cocaine anisocoria of 1 mm or greater is diagnostic of Horner syndrome on the side of the smaller pupil. Another case that we see in our clinic is light near dissociation, called Argyll-Robertson pupil. We see that the size of the pupil is smaller. Then the light reflex is is absent in this case. But when we ask the patient to converge, the near reflex was present. This was a 16-year-old male who presented with headache. There was also convergence retraction syndrome in the nystagmus, if you could note. This is the etiology, afferent or efferent pathway lesion or a dorsal midbrain syndrome, pineal tumor or Wernicke's encephalopathy. An MRI of this 16-year-old boy revealed a pineal gland tumor, as you can see here, marked in orange. Another case, he had a history, 28-year-old male with a history of road traffic accident a few months back. On attempted adduction, there was globe elevation, upper lid retraction, and synkinetic meiosis. The pupil is not very clear. So basically, it was an aberrant regeneration case. The take-home message is, it is a non-invasive examination. So it should be an integral part of each and every ophthalmic investigation. It is truly a window to diagnosis. We need to use a stepwise method with which we are comfortable. And a careful history will give you important clues to the etiology. Thank you.
Thank you, Dr. Ruhi. Thank you, Muscati sir, for being with us and giving us the valuable feedback. Thank you, sir. Come, let us have Ruhi. Huh? She's taking no problem. Yeah. Please come.